Hi, I'm a practicing psychiatrist as well as a psychiatric educator. And today I'd like to talk to you about 5 mistakes that I see in my field. These are not rookie mistakes made by the people I train, and they're not really controversies like the ethics of shock treatment, ECT, or hospitalizing people against their will. I'm not going to be talking about things like that. Instead, I'd like to talk to you about 5 issues that I think are relatively uncontroversial and that my colleagues would agree on if they thought about it. I'm Dr. Stephen Reidbord, and this is More Than Meds, where I talk about psychotherapy and psychologically informed psychiatry. The first is the phrase or the idea of chemical imbalance. Now, I talked about this in a previous video, right there, but I think this would be the first piece of sloppy thinking in psychiatry to tackle. As I discussed in the previous video, we don't know of any actual chemical imbalances in the brain that lead to psychiatric disorders, what we currently consider psychiatric disorders. Using this term chemical imbalance is often a kind of justification for prescribing and advising patients to take medications, and yet it's not necessary. The history of medical treatment is full of medications and other kinds of treatments completely apart from psychiatry that we've used without knowing exactly how they work mechanistically. Aspirin is a good example of that. We used it for decades without knowing how it worked, how it relieved pain or fever or inflammation. We know now, but we didn't know then. The same is true of essentially all of our psychiatric medicines, and that doesn't make them illegitimate, but what is illegitimate is trying to justify or explain the use of these medications by making up a story about chemical imbalances. Now, a lot of psychiatrists don't do this anymore. It's really become kind of outmoded to do this, but some still do, and I think that's really unfortunate. We shouldn't really be referring to an idea that is attractive, but there's no evidence for it at this point in our understanding. It's just not true. There are not chemical imbalances that explain what we treat. It sounds good, but it's misleading, and so we shouldn't do it. Number 2 is what we call polypharmacy. That's a fancy word for piling one medication on top of another, prescribing more and more medications for the same patient. It's generally understood in medicine, not just psychiatry, that doing that is hazardous and not advised. And that doesn't mean that it's never a good idea. Sometimes, in particular cases, it's required to use multiple medications, complex combinations of medications. But anytime any doctor does that, we really need to ask ourselves if it's necessary, because there's a lot of drawbacks to doing that as well. Adding one medication on top of another greatly increases the chances of side effects. It greatly increases the chance of drug-drug interactions where one medicine doesn't play well with another. Often we get into a situation where we're adding a medicine to treat the side effects of a previous medicine, and so we're just piling one medicine on top of another, and so it becomes a kind of vicious cycle, adding one medicine to deal with the previous medicine. There's no obvious end to that. And a kind of less well understood issue is that there have never been scientific studies of these combinations of medicines. There's so many possible combinations that there's no way really to study that scientifically. So in that way, it's not evidence-based medicine. I could tell you stories, mostly from earlier in my career, of meeting new patients who come to me on 6 psychiatric medicines. let's say an antidepressant, an anti-anxiety medicine, a sleeping aid, maybe a stimulant for ADHD, frequently a neuroleptic or antipsychotic medicine, not because they have psychosis, but because those medicines are sometimes also useful as tranquilizers or to assist antidepressants. And sometimes people come on two antidepressants. So right there, you have like 6 medicines, and I've even heard of more. Very frequently, in cases like that, my job is not prescribing a new medicine. My job is deprescribing. Deprescribing is a term that means carefully taking away medications because the patient's better off without them. And that can be challenging medically. Patients are afraid to decrease their medications. They've gotten used to them. They've come to believe they're necessary when in fact they might not be. But also we don't want to do this haphazardly or casually. We have to be quite careful when we deprescribe. And yet, I've had a number of patients who've been much better off on smaller numbers of medicines, or sometimes none at all, when they originally came in on 4 or 6 medications. Number 3 is chatting and calling it psychotherapy. Now, as you know, psychiatrists are trained and able to prescribe medications and also do psychotherapy. But sometimes some in my field just have a conversation with their patient during a medication visit. And if it goes on for a long enough time, they call it psychotherapy for billing purposes, for example. And that's well, for one thing, that's fraud. We shouldn't be calling something psychotherapy if it's not. But I think it's not an intentional fraud. I think it's a conceptual confusion about what is psychotherapy. And some of that confusion is because there is such a thing as supportive psychotherapy, which sounds like all you're doing is helping the patient by chatting with them. But that's not really what supportive psychotherapy means. Supportive psychotherapy has a more specific meaning. It means to help a patient use the best coping mechanisms or defense mechanisms that they have already, not to develop new ones. To give you a couple examples of that, a patient who's fighting psychosis sometimes will write things down a lot to help organize their thinking and organize their mind. If they were otherwise fine and didn't have any problems, we might think that all that writing down was a problem. We might think that's OCD or obsessive compulsive traits. But in the setting of psychosis, it's a pretty good coping skill. And so supportive psychotherapy would encourage that activity. Another example for someone who's got better functioning is the use of humor. Maybe they laugh off their problems. Now, that isn't necessarily the most ideal way to deal with problems, but for a lot of people, it's a pretty good coping skill. Humor is officially a defense mechanism, actually. But we encourage it if that's really the best the patient can do. And so that's supportive psychotherapy. Just spending time chit-chatting with the patient, having them talk about what's going on with their favorite sports teams or giving you the news of the week and so forth. It's not psychotherapy. It's also worth saying that we should be having friendly interchanges with patients no matter what we're doing with them. In a medication visit, we should have some rapport and be friendly. In fact, all healthcare providers should do that. That's called having a good doctor-patient relationship. That's not called psychotherapy. It should be expected in all healthcare encounters, and as such, it shouldn't be given a special name like psychotherapy. Psychotherapy is a treatment. It's intentional. It's being undertaken with the goal of helping the patient change something in themselves or at least maintain a certain level of functioning. It's not to pass the time, and it's not really just to improve the rapport between the two parties. That's not psychotherapy. Number 4 is reflexively putting people on involuntary holds, usually 3-day holds, for suicidal risk. This relates to commodity treatments, something I discussed in a recent video. I should say right off the bat, sometimes it is very helpful, sometimes it's really essential to hospitalize a patient who's acutely suicidal. I do believe we help save lives that way sometimes, even if the person is hospitalized against their will in the moment. Usually such hospitalizations are short-term, a few days, maybe up to a week, rarely longer. But depending on the patient, sometimes it's not helpful to do that. In fact, sometimes it's harmful to do that. Automatically hospitalizing anyone who has a lot of self-destructive thoughts or suicidal feelings is treating the symptom, not the patient who has the symptom. It's really important to try to understand what's going on. Is this coming from despair and hopelessness and depression? Or it could be coming from anger. It could be a kind of retaliatory threat. It could be a cry for attention and concern. It could be a way to make other people feel bad. And depending on what it is, leads to different kinds of approaches to helping the person with that. Hospitalization might be very helpful, or it might be very unhelpful. The key is to treat the patient, not the symptom. And last but not least is the idea that psychiatry is or should be a behavioral neuroscience, that we really ought to put all of our focus on understanding the brain underpinnings of psychiatric disorders and psychiatric treatments. I'm going to have a lot more to say about this, and in fact, I'm sure I'll do future videos on it. But for now, what I want to say is that, first of all, this isn't new. It's an idea that's been around at least since the 1980s, so decades now, to make psychiatry a medical, more scientific, quote-unquote, specialty. Millions and millions of dollars have been invested in brain research to try to understand psychiatric conditions. And I'm not against that. I think that's a good thing. I'd much rather we spent the millions of dollars on medical research than a lot of other things we spend millions of dollars on. But we have to be honest. Most of what we do, we psychiatrists in practice, doesn't depend on, isn't really informed by brain research. We do prescribe medications, but as mentioned, we don't really know the biological underpinnings of psychiatric disorders, and we don't exactly know why those medicines work. We just might know that they do, empirically speaking. Also, the medicines are very nonspecific. Most of our antidepressants also work as, and we use as, anti-anxiety medicines. A lot of our anti-anxiety medicines we use as sleeping aids. As mentioned earlier, a lot of our antipsychotic medications we also use as anti-anxiety medicines or to assist antidepressants. There's no specificity here. We just do the best we can. Our medications, our other medical kinds of treatments, and even our psychotherapy is not based on brain research, not at a basic level like that. Neuroscience will always be a part of psychiatry, but it will never be a complete account. So much of what we deal with, so much of what our patients deal with, are matters that are really at a higher level of organization than brain cells. They have to do with social interactions. They have to do with self-esteem. There's no brain cell for that. It's an emergent property, something I'll talk about in future videos. So I've given you 5 examples of what I consider to be sloppy thinking in psychiatry. These are not really issues that attract a lot of debate and controversy. They're not the hot topics in psychiatry. And I really want to emphasize that it's It's not because psychiatrists are evil or nefarious. We're not scheming agents of the state to smash creativity and difference, as some people claim. But it's all too easy to fall into habits that aren't ideal. And after all, we're human too. Please share your thoughts in the comments. Are there other mistakes you see in the practice of psychiatry? I'd be curious to hear what you think. Please subscribe if you have not already, and please like this video, but only if you really like it. And if you do like it, check out this video, which I think you'll like too. Thanks, and until next time.